you answered this morning half of the question. Have we reached the limits of lipid lowering and outcomes? And you said the answer in the morning for the outcomes, so I will go into the lipids. And this is an important topic now because we have more efficient medications to reduce LDL cholesterol to levels that have not seen before with statin therapy, or it were very exceptionally seen. So these are my disclosures for this presentation. I don't have any conflict of interest. And probably the question is, how low should plasma LDL cholesterol be to reduce the atherosclerotic cardiovascular disease risk to the minimum? And first, we have to remember that atherosclerosis is a chronic, progressive, and multifactorial disease starting early life. Therefore, beyond LDL cholesterol, there are other risk factors that should be identified in a patient or in an individual and managed to reduce the atherosclerotic burden. And this is the outline of my presentation. Well, what we can consider or could consider a physiologically normal LDL cholesterol. There are some data that suggest that keeping a low LDL cholesterol, below 100 probably, since early ages through the life of an individual can avoid atherosclerosis, of course, together with the control of other cardiovascular risk factors, but can avoid atherosclerosis in most patients. Most of people are born with an LDL cholesterol around 40 milligrams deciliter for plasma levels, and rise quickly after birth to levels around 70 to 90 milligrams deciliter, and then slowly progress through adolescence until early adulthood. And there are some prospective cohort studies, like the Bogalusa study, the FINS study, that have shown that LDL cholesterol is an independent predictor in adolescence for preclinical atherosclerosis measured in early adulthood through intima media thickness. Also, we know about populations that have low levels of cholesterol and do not manifest coronary heart disease. And one example here is the Tsiname indigenous population in Bolivia. And this study, with CT scan, showed that people over 40 years old have an average of 90 milligrams deciliter of LDL cholesterol, and most of them do not have coronary artery calcification. And some genetic studies have shown that loss of function mutations in PCSK9 and angiopoietin-like 3 are associated with low levels of plasma LDL cholesterol and protect against coronary heart disease. And you know that the ARIC study showed after 15 years of follow-up in the African American population, individuals of the ARIC study, that those individuals with loss of function mutation in PCSK9 after 15 years had 28 lower LDL cholesterol levels and 88% reduction in coronary heart disease risk. Also, there are some case reports published of healthy middle-aged men and women with loss of function mutation in PCSK9. These people usually have LDL cholesterol around 15, and they are protected against coronary heart disease. Move to the other side, relationship between LDL cholesterol or LDL and atherosclerosis. And there is a large amount of evidence, it's robust evidence and consistent evidence showing that LDL is a major causal agent for atherosclerosis. Of course, the other lipoproteins, it has been discussed before, the remnants of VLDL, etc., are also, and Lp(a) are also implicated in the initiation and progression of the disease. But most of the studies have been focused on LDL as a primary target, so I will focus mainly in LDL cholesterol. And there are evidence coming from prospective epidemiological studies performed in patients and family with familial hypercholesterolemia, Mendelian randomization studies, we have heard a lot about this in this session, and randomized control trials. The epidemiological study, Mendelian randomization studies, and randomized control trials have shown consistently a dose-dependent log linear association between the magnitude of exposure to LDL cholesterol and the benefit in cardiovascular risk, increasing the effect with increasing the exposure to LDL cholesterol. Well, some few words about familial hypercholesterolemia. You know, you work a lot here in Brazil in FH. FH is a very common monogenic disorder caused mainly by LDL receptor mutation genes and less frequently ApoB or PCSK9. The prevalence is 1 in 250, and it is highly associated to premature cardiovascular disease. And there are some data from different studies. I worked in the Safe Heart in Spain. This is a FH population with genetic diagnosis and their unaffected relatives. And you can see that the odds ratio for atherosclerotic cardiovascular disease is 3. This population is mostly treated against their unaffected relatives. Also in the Copenhagen general population study, a huge number of general population with different criteria for FH. Some of them were genotyped. The odds ratio was 13.2 in those with definite probable diagnosis of FH compared with unlikely FH. And finally, the KERA study, you know, that genotypes a huge amount of people from different cohort study, and he found an odds ratio of 22 in those individuals with an LDL cholesterol over 190 and also with a mutation in a FH gene, and compare with those below 130 and without mutation. Therefore, independent of the diagnostic criteria, if you have FH, you have a high risk for coronary artery disease. Mendelian randomization studies. Well, the concept is that there are many variants that are associated to LDL cholesterol, and the randomization occurs in the conception. You can inherit one allele associated to low LDL cholesterol levels, and this is like to be randomized to an active treatment arm since early life, and the others are like the usual care. So Mendelian randomization studies have shown that variants associated with low LDL cholesterol are associated with lower risk of coronary heart disease. As shown here, you see that the higher the exposition to lower LDL cholesterol, the higher the benefit. This is in the log scale, logarithmic scale. And moreover, the risk reduction in LDL cholesterol produced by each of these variants produce a similar risk reduction. It is around 18%, strongly suggesting that the effect of these variants depend on LDL cholesterol and not of the mechanism why LDL is lower. But the most compelling evidence from causality comes from randomized controlled trials evaluating different lipid-lowering treatment with cardiovascular outcomes and also progression, regression, coronary atherosclerosis using intravascular ultrasound studies. Statins are effective, and I think that they change, you know, when we have availability, early 90s, it changed the way we prevent cardiovascular disease. In this meta-analysis, after a median follow-up of 5 years of statin treatment, the overall risk reduction per millimole LDL cholesterol reduction was 22%, and it was independent of baseline LDL cholesterol levels. In statin versus control trial, the MACE risk reduction was 21% and 28% in those trials with high intensity versus less intensive statin treatment. During the first year of treatment, this risk reduction was small, around 10%, but increased to 24% and keep constant 24% each subsequent year of statin treatment. Although, and this is important to know, you know, because this was something that changed our conception, our management of patients with the guidelines in 2013 with the American Heart and ACC, because in this statin randomized trial, patients were not allocated to a specific LDL cholesterol level target. Although there is the association between achieved LDL cholesterol here in each randomized treatment arm, in each trial in primary prevention and secondary prevention, is a linear association, you know, between those variables, suggesting that in primary prevention, an LDL cholesterol below 50, and in secondary prevention, an LDL cholesterol below 30 could predict 0 events. We know that it doesn't happen, but, you know, but it's interesting how it worked, the data came. And In the post-hoc analysis of Jupiter trial, this is very interesting. In Jupiter, patients were randomized to Rosuvastatin 20 versus placebo, median follow-up 2.8 years. And you can see that those patients allocated to Rosuvastatin that achieved an LDL cholesterol below 50, this is the median LDL cholesterol at year 1 in this population, had 65% reduction of primary outcomes compared to placebo, and also 61% compared with those allocated to Rosuvastatin but do not achieve an LDL cholesterol below 50. And this is the median LDL cholesterol in this population. Therefore, the authors suggested that if there is a threshold, it may be below 50 milligrams deciliters. Furthermore, the studies with IVUS have shown that progression of atheroma can be arrested with LDL cholesterol below 80 milligrams deciliters, and regression can be observed with LDL cholesterol below 70. This was, these different trials with high-intensity statin versus less intensive statin, and also the precise IVUS study with atorva and ezetimibe. Well, statins are effective. And this was summarized by Collins in a publication in Lancet in 2016, when it's a very interesting and very beautiful publication. And she said that lowering LDL cholesterol by 2 millimoles, it means around 80 milligrams deciliter, with an effective statin treatment during 5 years in 10,000 patients, you could prevent major vascular event in 10% high-risk patients and 5% low-risk patients. And this data outweighed the risks that would be expected. And the risks are 50 to 100 new cases of diabetes, few cases of myopathy, and few cases of hemorrhagic stroke. So plotted together, the data from Mendelian randomization study, epidemiological studies, and randomized controlled trials, the clinical benefit for per unit change in LDL cholesterol, if we use this to measure the same data in all the study, is 3 times greater in those people that are long-term exposure to low LDL cholesterol, coming from Mendelian randomization study, than those, but of course it is important, but those that are short-term exposure to low LDL cholesterol because they are treated with statins, and the median follow-up was 5 years. Therefore, reduced cholesterol is important, yes, but also the time. This reflects the cumulative effect of lifelong low LDL cholesterol. Well, they are safe. Yes, they are safe. In general, statins are safe. And one of the main concerns, rose many years ago when in the Jupiter trial, the description said that there were more risk of diabetes, new onset of diabetes. And first of all, to emphasize that statins have been demonstrated cardiovascular benefit in diabetic population. But statin can increase the risk of new onset diabetes. And this data comes from randomized clinical trials and meta-analysis. And it's between 9 to 12% is a dose-dependent effect, and mainly observed in patients with prediabetes or with risk factors for diabetes. But what it is important, the benefit always outweighed the risk. Mendelian randomization studies confirmed these findings, and per 10 milligram deciliter decrease in LDL cholesterol, the odds ratio for diabetes was 1.13, 13% more, and the odds ratio for myocardial infarction or death from coronary heart disease, 0.81, 19% reduction. However, despite statin treatment, many of our patients still develop coronary events, cardiovascular events. And there are many factors, some of them are related to lipids, and some of them related to other cardiovascular risk factors that can be connected. Here, inflammation, Peter Levy talked about this morning, but the control of other risk factors, our population continues smoking, 20% continue smoking, and obesity is a big problem in our countries. In Chile, at least more than 35% are obese and 75% obese overweight, being the second country with more obesity in the OCDE countries. So we can work on this, but we cannot forget this. And in lipid-related factors, we have LDL cholesterol not on goal. This is very important. And some real data from the US say that 40 to 70% of high-risk patients achieve an LDL cholesterol below 100 and 50 to 13% an LDL cholesterol below 70 with high-intensity statin treatment. So still we have a lot of work to do. And one important issue is the low compliance. More than 50% of patients stop medications after 1 or 2 years after a cardiovascular event, and that is not possible. Also, the variability in LDL cholesterol response, statin intolerance patients, patients with FH, high Lp(a), and other lipids. Talking something about the variability, this is another post-hoc analysis of the Jupiter, and it has been observed with all statins in the Voyager study. But in this post-analysis, you can see that less than 50%, 46% of patients allocated to Rosuvastatin 20 milligrams achieve an LDL cholesterol reduction 50% or more. 43% below 50, and 11% not reduce or also increase the LDL cholesterol level. But this has an impact, in cardiovascular risk, and you see that those patients who respond the most have 59% less risk for primary outcomes compared to placebo, and those who respond less, a 39% reduction. And if we move not from percent variation, because there's a huge variability in the response, some people respond more than others, also in achieved absolute LDL cholesterol level or other targets like non-HDL cholesterol or ApoB, you can see in this meta-analysis with in highest risk population with atorvastatin 80 or rosuvastatin 20, that more than 40% of patients still have an LDL cholesterol over 70. And that there is a huge variability, a large inter-individual variation, showing that some patients respond better than others. And this, of course, also has an impact in cardiovascular risk. And in this meta-analysis, those patients achieving an LDL cholesterol below 50 has an hazard ratio adjusted for other cardiovascular risk factor of 0.44, meaning a reduction of 56% of primary outcomes. Well, what are the other treatments add for the residual cardiovascular risk management? And we have to talk about the ezetimibe and PCSK9 inhibitors. Well, you know that in the IMPROVE-IT, patients were post-acute coronary syndrome were randomized to simvastatin 40 or ezetimibe plus simvastatin, and the inclusion LDL cholesterol should be between 50 and less than 100 milligrams deciliter. And after a median of 6 years of treatment, the LDL cholesterol in the ezetimibe arm was reduced by 13 milligrams deciliter, and the primary composite outcome was reduced in 6.4%. This was not too much, was we wanted to observe, but it was that it should be. And also in some other posterior analysis, it has been shown a 9% reduction, not only in the first event, but also in total events. It means that primary and subsequent events, with this has, of course, a very important significance from health cost systems. This is very interesting because patients achieving an LDL cholesterol below 30, that are 6% of the patients of the IMPROVE-IT trial, had the lowest hazard ratio of primary outcomes. It's almost 18% reduction compared to those that remain with an LDL cholesterol over 70 milligrams deciliter. Therefore, with these trials, you can see that still in the best scenario, or probably best scenario with statin, we still have a high cardiovascular residual risk, and that we can reduce a little bit with ezetimibe addition. The question remains whether further reduction in coronary heart disease risk can be achieved lowering LDL cholesterol further, the levels observed with statin trials, or statin with ezetimibe. And these are phase 3 studies with PCSK9 inhibitors. PCSK9, the development of monoclonal antibodies against PCSK9 has revolutionized the lipid management and cardiovascular prevention. And you can see in all of this population that where PCSK9 inhibitors are first indicated, heterozygous FH, statin intolerance patients, and high-risk patients, on top of statin, have shown a consistent reduction of more than 45–50%. Of course, depends on the comparator, but it has demonstrated, that a huge reduction in LDL cholesterol without safety concern or important safety concern. Well, we saw before that high-intensity statin, achieving LDL below 80, we can have arrest progression, and below 70, we can have regression. The GLAVO trial was conducted to evaluate progression of coronary atherosclerosis with evolocumab, and here we have the baseline data. Patients with an LDL cholesterol over 80 milligrams deciliter on stable statin dose were allocated to evolocumab or placebo for 18 months, and after 18 months, you can see that the primary endpoint that was change in percent atheroma volume was significantly different, in the statin evolocumab arm compared with placebo. 64% of the patients on evolocumab showed regression, and this number, or this percentage, increased up to 82% in those patients that started evolocumab with an LDL cholesterol at baseline below 70. And on your right, you have an exploratory post-hoc analysis, a regression curve showing, an inverse relationship between on-treatment LDL cholesterol and progression without threshold effect below 20. And if we move to the hot endpoints or cardiovascular outcomes, Fourier trial was the first randomized control cardiovascular outcomes trial with evolocumab with an PCSK9 inhibitor reported. And you remember that more than 27,000 patients with stable atherosclerotic cardiovascular disease and additional risk factor with an LDL cholesterol over 70, that were treated in a stable statin treatment with or without ezetimibe. Here could be high or moderate dose of statin, and were allocated to placebo or evolocumab, and the median follow-up was 2.2 years. Here you have the changes in LDL cholesterol, a significant 59% mean reduction in LDL cholesterol. 69% were receiving high-intensity statin, and 5% were receiving also ezetimibe. 42% of individuals, and we will see the importance of this later, achieved an LDL cholesterol below 25. And you can see on the right, that there was a 15% risk reduction on primary composite outcomes in those patients allocated to evolocumab compared to placebo. Pre-specified analysis and post-hoc analysis have shown also, like in the IMPROVE trial, but this, you can see the percentage is higher. Evolocumab reduced not only the first event, but also total events, primary and subsequent, by 18%. And the effect was similar regardless baseline LDL cholesterol. Patients below 70 or over 70 respond the same, and regardless the statin therapy, it was maximal or submaximal dose of statin. And then we have the ODYSSEY outcomes trial reported. Different population, post-acute coronary syndrome with an LDL cholesterol over 70, but here patients should be treated with high-intensity statin, defined like atorvastatin 40/80 or Rosuvastatin 20/40, and randomized to alirocumab or placebo for a target LDL cholesterol between 25 and 50. We didn't have this in the 4-year trial. And the median follow-up was 2.8. And here you can see the changes in LDL cholesterol from baseline to the 4th year, significant 54.7% reduction in LDL cholesterol. 85% were receiving high-intensity statin, and 3% also ezetimibe. And you can see on your right also that it was a 15% reduction in primary composite outcomes. An interesting result was also that lower cases of total mortality was observed, and with a nominal p-value of 0.026. This is because the pre-specified statistical analysis. And risk reduction was greater in those patients with a baseline had an LDL cholesterol over 100 milligram deciliter. And a recent post-hoc analysis showed that alirocumab also reduced the total burden of the disease, reducing not only the primary event, but also the subsequent events. Cardiovascular, non-fatal cardiovascular event by 13%, and total mortality. This includes the first, of course, who died, and then the people who died in the follow-up by 17%. About safety, they are safe, yes, in short period of time. Because the first was 2.2 median, the second was 2.8 median. Of course, we have patients treated for 4 years in ODYSSEY outcomes, but in general, it was safe. No neurocognitive adverse event, no problem with liver enzymes. The only difference was local site reaction for both of them compared to placebo. What happened with those patients who achieved a very low LDL cholesterol with these drugs? And this was a pre-specified analysis of the 4-year trials, because here there was not a target to treat so there is 10%, more or less, to 2016 patients that reach an LDL cholesterol below 20. And you can see the hazard ratio is 0.76, means that it's a 24% reduction compared to those that have an LDL cholesterol over 100. And you see a monotonic curve, relationship curve here, down from 100 to levels below 20. No safety concern, in all of this group was observed. And go further, what happened with those that achieve an LDL cholesterol below 10? 500 patients achieve in the 4-year trial this level of LDL cholesterol, and also you can see there is a hazard ratio of 0.69, so 31% reduction in primary composite endpoints and 41% in secondary endpoints without safety concern. Again, in this short period of time, 2.2 years of median of follow-up. Well, statin protect, but also produce diabetes, no? Small amount, small percentage. What happened with PCSK9 inhibitors? Well, Mendelian randomization studies have shown that genetic variants in PCSK9 are associated with an increased risk of new onset diabetes, and the odds ratio is 1.11 per 10 milligram deciliters in reduction in LDL cholesterol produced by these variants. What happened in the trials? In the 4-year trial, there were 11,000 patients with diabetes at baseline and 16,000 patients without diabetes. And evolocumab protect. Reduce cardiovascular outcome in patients with diabetes and without diabetes in a similar degree. And there were no more incident new onset diabetes in the trial. You can see after the end of the first year, the second year, or the third year. And recently was published the data from the ODYSSEY outcomes in patients with diabetes and without diabetes, and stratified by glycemic status, and you can see that the relative risk reduction was the same, independent of if the patients had normoglycemia, prediabetes, or diabetes, although the absolute risk reduction was higher in the diabetes population because they have a higher risk before. And again, no more incidence of new diabetes in this population. So produce or not produce diabetes. I think we have to wait and see what happens. What about other lipids? Peter talked about fibrates, about HDL, about reduce it with this purified eicosapentaenoic, producing a 20% reduction in triglycerides and a 25% relative risk reduction in primary outcomes in patients treated with statin with an LDL cholesterol below 100 and high triglycerides. And about Lp(a) that was asked this morning, Lp(a) is a risk factor for coronary heart disease, aortic stenosis, and stroke. We know that PCSK9 inhibit or reduce Lp(a) level by 25 and 30%, but a recent post-hoc analysis of the pooled data from ODYSSEY shows that this can be okay and translated into reduced cardiovascular outcomes in those populations that have Lp(a) over 50 milligrams deciliter. There are new medications, antisense therapy, reduce Lp(a) to levels up to 90%, but we don't have evidence from randomized controlled trials about the benefit to reduce Lp(a) and MACE risk reduction. How we reach the limits? Well, what are the limits we have now? And here you see the evolution, in the last 20 years. When I was in the middle of working in Madrid about lipids, we used ATP3. We had, below 100 in high risk, below 70 in the update in 2004. We had targets, regarding according to the cardiovascular risk of our patients. And then in 2013, we had the new guidelines, more evidence-based, based mainly in statin trials, because we didn't have evidence from ezetimibe or the new PCSK9 inhibitors. So no LDL cholesterol targets were considered, and they said use high-intensity statin to produce more 50% reduction in LDL cholesterol level. You have to measure your LDL cholesterol because you need to know if your patient is taking medication, safety, and you obtain this 50%. And to obtain that, you have to use atorvastatin 40/80 or rosuvastatin 20/40. In Europe, in the other side, they continue working with targets, and they propose very high-risk patients, LDL cholesterol below 70, or an LDL cholesterol reduction over 50% if LDL cholesterol is between 70 to 135. We'll see what's up in the next guideline that we delivered in the ELSE Congress in Paris this year. But the last year, in November, the new guidelines from the American Heart ACC continue, with risk in the population, in primary care with the risk. They change the percentage of risk and use target in two situations. In those patients with very high risk secondary prevention, patients with secondary prevention over 18 years old that continue with multiple episodes of cardiovascular disease or more risk factors, and in primary prevention, patients with LDL cholesterol over 190, where most of our FH patients are. First, use high-intensity statin. If you control the patients and continue with an LDL cholesterol over 70 in this very high risk, or over 100 in this primary prevention, over 190 baseline patients, add ezetimibe, and when you control, if you continue with over 70 or over 100, add PCSK9 inhibitors. So the answer, if we have reached the limits, I think that in lipids I would like to say yes, because we are getting very low LDL cholesterol, at least in LDL cholesterol, because we can achieve LDL cholesterol around 10 with these new drugs on top of statin treatment. But in terms of atherosclerotic risk reduction, the answer is no, and Peter explained very well this morning. Still, we have to wait for the cardiovascular benefit of other lipid agents, like inclisiran, alirocumab, bempedoic acid, that have been shown benefit in reducing LDL cholesterol and other lipids. In conclusion, and to finish, cholesterol is cause of atherosclerosis. Reduction of LDL cholesterol means reduction of the risk, and cardiovascular benefit is proportional to the absolute change in LDL cholesterol we can get with statins. The first line are statin plus ezetimibe, and then probably plus PCSK9 inhibitor. And It depends on how much we reduce and how long we keep this LDL cholesterol reduced. There are no safety concerns in short time with very low LDL cholesterol, but we don't know what happens long term with these new drugs. And still, we have a high residual cardiovascular risk in patients treated with statins. So we have to optimize statin treatment first, manage all other cardiovascular risk factors, and of course, we can manage a little bit more further LDL cholesterol and other lipids. If we should change, or there is should LDL cholesterol target be modified, reduced for high-risk patients, I think this is a matter still on debate. Thank you very much.